Good morning, everyone. So welcome to Grand Rounds again. We've got a very interesting topic this morning. We've got neuro-ophthalmic disorders in pregnancy, both common and uncommon. Although to most of us, all of that is probably uncommon. So I look forward to the talk this morning. Our faculty member is Dr. Rahul Sharma, who is a neuro-ophthalmologist practicing at both Trillium Health Partners and Sunnybrook Health Sciences Center. He completed his ophthalmology residency at the University of Ottawa before pursuing a neuro-ophthalmology fellowship at Emory. Since coming back, he's had a keen interest in medical education and mentorship, and has been recognized for his work in this space. He's a frequent contributor to the Neuro-Ophthalmology Virtual Education Library and serves on the Young Neuro-Ophthalmologist Committee for NANOS, which is the North American Neuro-Ophthalmology Society. I look forward to his talk this morning. Rahul's a good friend of mine. He's a very smart guy. So for those of you who don't know him, I look forward to introducing you to Dr. Sharma this morning. So the floor is yours.
Thanks so much, Amandeep, for that very kind introduction. So as you've heard, we're discussing neuro-ophthalmic disorders in pregnancy, both common and uncommon. And so we start by recognizing that pregnancy is a period of drastic physiologic change in the human body. There's an expansion of blood volume. There's an increase in cardiac output. Women are hypercoagulable. They're relatively immunosuppressed. And of course, they're gaining weight. And so you can imagine that these factors can influence a number of neuro-ophthalmic disorders shown here on the slide. Today, we're focused on two. And the first is idiopathic intracranial hypertension. So before Yusuf dives into IIH and pregnancy, I thought I'd use my portion of the rounds to talk about idiopathic intracranial hypertension in general, sharing some clinical pearls on the approach to these cases. And the reason that IIH is such an important topic is because much in the way that we're expecting a tsunami of glaucoma cases because of changing demographics, we should anticipate an increase in IIH cases with the rising obesity epidemic. This data is from the US, and it tells us that over a 7-year period, we're seeing 1.35 times the number of IIH cases. And with respect to obesity, unfortunately, Canada is not far behind. So we have to be aware that we will see more and more IIH. Now, when you are sent a patient for possible papilledema, particularly if the papilledema is mild or appears mild, you're probably considering the possibility of pseudoedema due to causes such as optic disc drusen. So as a first pearl, I'll share that if a patient is sent to you from the ED, the likelihood is they've already had a CT scan, and reviewing that CT scan can reveal the diagnosis. So you can see at the bottom there, in a gentleman that was sent to us for possible papilledema, we see calcific optic disc drusen in the optic nerve head. That's quite visible. It won't be reported on the CT report. And so by diagnosing this, you can obviate the need for a papilledema workup, and you can forego any further ophthalmic imaging. Now, if you want to order an imaging study in your office for drusen, you should consider EDI-OCT. This is now the gold standard, and image is shown there in the top right. I've included a citation at the bottom and a QR code for a paper. These are the diagnostic guidelines that were put forth by the Optic Disc Drusen Consortium from NANOS. And the reason this is such a helpful paper is there are step-by-step instructions, a protocol for your OCT so that you can obtain the images necessary to diagnose drusen. And if you're looking at the scan, what you are looking for is a signal poor area, a hypo-reflective space, often with a hyper-reflective margin that's shown by the white, yellow, and red arrows. The blue are blood vessels. Now, if the patient truly appears to have bilateral disc edema, you have to reflexively check the blood pressure. And if the patient comes to you from anywhere other than the ED, for example, from a family physician or another eye care provider, they probably have not had the blood pressure checked during the acute episode. And so you want to check the patient's blood pressure because the appearance of hypertensive disc edema can be clinically very difficult to distinguish from papilledema. And in some cases, patients have both. Now, in the case of hypertensive retinopathy, we know disc edema is a severe sign, right? It's grade 4 hypertensive retinopathy. So we also look for earlier features like arteriolar narrowing, AV nicking, exudate, hemorrhage, cotton wool spots, but sometimes the attention is drawn to the disc, and these patients are presumed to have papilledema. And in the case I'm presenting, the Optos photos below show very severe bilateral disc edema with hemorrhage and cotton wool spots. The patient had a markedly elevated blood pressure indicative of hypertensive emergency. They were admitted to hospital, they were managed for this, but we suspect that they probably had two diagnoses because headache is a shared feature between hypertensive emergency and IIH, but they had additional symptoms to indicate intracranial hypertension, like transient visual obscurations and pulsatile tinnitus. And they also had radiographic imaging features that indicated high ICP. Their papilledema persisted for quite a bit, even after the normalization of their blood pressure. Now, as we move on in PEARLS for IIH, we think about history taking. And of course, we ask about headache in IIH patients because it's a near universal feature. The phenotype of the headache is most often migraine-like. And what an ophthalmologist should know is that the ICP is very poorly correlated with the severity of the headache. And so if you are seeing these patients and you're treating them with acetazolamide for their papilledema, you may hear that even after the papilledema has resolved and the ICP is presumed to be normal, they may have very bothersome headaches. And so in these cases, what we don't want to do is continue the treatment with acetazolamide without a moment of pause, because what the patient might be experiencing is an exacerbation of pre-existing migraine or headache that is related to medication overuse or exacerbated by comorbidities like anxiety and depression. These are situations where we really want to involve the family physician or our neurology colleagues and not simply continue Diamox treatment. Continuing the theme of history taking, we need to think about causative medications. And these cases of intracranial hypertension that are precipitated by medication, they're not truly idiopathic. It's a secondary intracranial hypertension. We should ask specifically about tetracyclines and about vitamin A containing compounds, both orally and topically. Keep in mind that some patients for acne are on both. The case that I'm presenting there is of a young, non-obese woman who had symptoms indicative of high intracranial pressure. She had normal neuroimaging. Aside from features of high ICP, she had an elevated opening pressure. And what was fascinating about this case is she had been prescribed a naturopathic formulation at doses of vitamin A that are sufficient to precipitate hypervitaminosis. So these patients have high ICP from the vitamin A medication. We withdrew the medication and treated with Diamox, and she did very well. There are medications, though, that there's a persistent notion, at least with respect to OCP, that it acts as a risk factor for IIH, in spite of accumulating evidence that it, in fact, is not. And so this paper is from 2018, several years ago. It's from the Mayo Group, and they looked at the largest population-based data study that we have available, and they found that, in fact, OCP is not a risk factor for IIH. And the caveat is we should still probably ask about this medication in patients with papilledema because of the potential association between types of OCP and dural sinus thrombosis, which can cause papilledema. But with respect to IIH specifically, it seems that OCP is not a risk factor. And what we don't want to do as ophthalmologists is discontinue the oral contraceptive in our patient with presumed IIH because of, among other things, the possibility of unplanned pregnancy. To touch quickly on two important comorbidities in IIH patients, we'll discuss first anemia. And I've cited a paper here from Jonathan Michelli, who of course is a neuro-ophthalmologist here in Toronto. And the take-home messages here is that anemia is very common among IIH patients. And interestingly, treating the anemia alone can promote resolution of the papilledema even without additional pharmacological treatment. What I would say is that many of these patients have already had a CBC. And so reviewing this can allow for an eventual diagnosis of anemia. Of course, you should ask the patient as well. And in other cases, you should feel compelled to request a CBC or recommend that the family physician do this. Sleep apnea is another important risk factor. And continuing the theme of local literature, there's a paper from Ed Margolin and some co-authors here in Toronto. And you can see that they have indicated to us that sleep apnea is present in the majority of IIH cases and probably an under-recognized risk factor. So in atypical cases, such as non-obese patients or men, we want to think about the potential contribution of sleep apnea. OSA is thought to increase ICP via a number of potential mechanisms. And so we do want to ask the patient about symptoms that could suggest sleep apnea. We want to ask about potential prior diagnosis. Some of these patients have known sleep apnea and they're simply non-compliant with CPAP. And even if not, we should consider in atypical cases suggesting a sleep study to the family physician. Switching gears now, we should talk about radiographic findings of intracranial hypertension, not just IIH, but any cause of high ICP in the brain. And so with respect to IIH specifically, we know that the diagnosis is made based on modified Dandy criteria, which tells us that imaging in these patients, it doesn't show mass or thrombosis, it doesn't show hydrocephalus or a leptomeningeal process, but it does have abnormalities. And the abnormalities reflect chronically increased ICP, sorry for the dimmed light there. Essentially, what we are seeing are the effects of increased cerebrospinal fluid on various locations of the brain, which shows up as squished pituitary, a partially empty sella or tonsillar ectopia, descent of the cerebellar tonsils. We can see flattening of the posterior aspect of the globe or expanded fluid in the optic nerve sheath. Perhaps most important is the presence of transverse venous sinus stenosis shown on the bottom right. And we're going to come back to this in a moment. But the reason that I think it's important that we review these radiographic features is because although we expect them in patients with intracranial hypertension, we also see them in a segment of the normal, healthy population and those who had previous high ICP that has since normalized. So we call this RAD-IIH. And what's involved here is that the patient undergoes an MRI, perhaps for a completely unrelated indication, and the radiologist tells us that there's a feature indicative of high ICP. They may even indicate idiopathic intracranial hypertension on the report, and then you are sent the patient for the ophthalmic assessment, but they may not have IIH at all. And my favorite study looking at this topic involved imaging these patients that were going into the MRI for any indication. Some of them were having routine imaging for monitoring of a neoplasm, for example, and they took pictures of the patient's fundus, and then they reviewed the MRI for features that are compatible with high ICP. And interestingly, they found at least one feature in about half of patients, but only the minority had papilledema. So be on the lookout for that. Finally here, I'll touch on a component of the presumed pathophysiology of IIH. And I should say that IIH remains idiopathic. We don't know if this is a hormonal disease, whether it's a metabolic disease, whether it's influenced by genetic factors, but we are increasingly aware of the contribution of venous sinus disease in the pathophysiology of IIH. And what you should know is that CSF outflow occurs when the CSF pressure exceeds venous pressure. So if we have increased pressure in the venous system, the CSF pressure rises. And accordingly, we do see venous sinus stenosis, as I've said, in the majority of IIH patients, as much as 93%. The stenosis in the venous sinus system, it may be extrinsic or it may be intrinsic. Intrinsic means we have perhaps septations within the venous sinuses or enlarged arachnoid granulation, something that's obstructive, whereas extrinsic means that the ICP is high and it exerts a mechanical effect on the venous sinuses. It collapses the venous sinuses, inducing the stenosis. And accordingly, we have this collapsible model theory, which means high ICP in the patient's brain promotes the stenosis. The stenosis reduces CSF outflow, which increases high ICP, and we've created a vicious cycle, a sort of positive feedback loop. And we hope to disrupt that positive feedback loop by bringing down the ICP, either pharmacologically or with a surgical intervention. The one that is specific to the venous sinuses is venous sinus stenting. This is still only 2 decades old, but it's becoming more and more common. And if we can demonstrate a transstenotic pressure gradient, perhaps a stent can be inserted there in order to address this underlying pathophysiology. As a point of added interest, I'll just add that we're accustomed to asking about pulsatile tinnitus, and what we're really asking about in IIH patients is whether or not they're experiencing a bruit from the accelerated and turbulent blood flow through this area of venous sinus stenosis. So to tee up Yusuf for his portion of the talk, I'll ask you to consider a classic IIH case, a young overweight woman with high ICP symptoms, normal visual function, bilateral disc edema, and we know what to do in these cases diagnostically, and we know what our therapeutic options are. But all of a sudden, if we make this patient pregnant, you can see how the situation becomes quite a bit murkier. We're wondering about the role of gestational hypertension. We're considering the safety of contrast agents and imaging and the possibility of radiation exposure. We're thinking about how to advise the patient regarding their weight during a period where they're expected to gain it. But in typical IH cases, we recommend weight loss. And then finally, we're thinking about the safety of the treatment options, including medications and surgery. So to dive into these issues, I'll hand it over to Yusuf. for our first two cases.
All
Well,
right.
that was excellent, Rahul. Thank you for that summary. That was very good. Yusuf, the floor is yours.
We all good?
Yes.
All right. Hey, everyone. My name is Yusuf. I'm a second-year resident at the University of Toronto. I'd like to thank Dr. Sharma and also Dr. Tyndall for both of their inputs on this slide and this presentation. So without further ado, I'll go ahead and pick up from Dr. Sharma. Before I get into the case, I'd like to just prime the audience with a few discussion points. So the first being, what alternative causes of intracranial hypertension should specifically be considered in pregnancy? How does IIH differ in pregnant patients? Can MRI brain with contrast be safely performed? Is lumbar puncture required? How safe is acetazolamide and when should it be used? How should weight gain and loss be discussed? And then lastly, what are non-pharmacologic treatments options that are available and what are the risks? So the case starts off with a 28-year-old female who was referred by her ophthalmologist for query papilledema, and her past ocular history and her past medical history were unremarkable. Her medication list did include a prior use of tretinoin, which is a vitamin A derivative, but not for some time. And she did have chronic headaches, although she didn't have any pulsatile tinnitus or transient visual obscurations. As far as her physical exam went, she did have an increased BMI of 31 with a weight of 216.4 pounds, although no recent weight gain. Her blood pressure was normal, as Dr. Sharma mentioned, important to measure that in the office. And her physical exam, at least apart from the fundus, was also unremarkable with normal visual function, color vision full, anterior segment exam normal, and the orbit normal. Her posterior fundus exam in the pole did reveal moderate disc edema in both eyes without other retinal findings such as retinal hemorrhages, exudates, cotton wool spots. So apart from the disc edema, which she did have, her fundus was normal. Her visual fields were also unremarkable without an enlarged blind spot or visual field constriction or scotoma. And on the RNFL OCT, we can see confirmed corroborating our fundus findings of increased average RNFL thickness in the low 200s, which did confirm the moderate disc edema. And our ganglion cell analysis was normal as well. At this point, an MRI-MRV was initiated, which showed bilateral transverse venous sinus stenosis and also a partially empty sella, which would be in keeping with an IIH diagnosis. And in addition, there were no secondary causes identified on imaging, including leptomeningeal enhancement, mass, hemorrhage, and so on. So at this point, a diagnosis of IIH was made. At this point, we also had to consider whether this patient needed a lumbar puncture or not. And the answer to this is it really depends who you ask. The typical practice, oftentimes in Ontario, is in a typical patient demographic. So a young obese female with high quality imaging, a lumbar puncture doesn't always have to be done. It can be deferred. Although, we did bring this up with the patient, she was adamantly opposed to the idea of a lumbar puncture after discussing the risks, benefits, indication for it. So we were okay to defer it in this case because of her typical demographic, normal visual function, and lack of secondary cause on high quality imaging. The decision whether to treat this patient pharmacologically is also subjective. And we know that from the IIH treatment trial, patients who have a 5 to 10% weight loss do have improved papilledema. But in our case, our patient was disillusioned by the idea of weight loss. So we did decide to start on Diamox 500 milligrams BID and then follow them up in 3 months to see how they responded and see if they were tolerating. They would let us know in the meantime. So the patient was seen in 3 months follow-up, and at this point, they had told us of news of a pregnancy. So they were 8 weeks pregnant at this point. And in this interval period from the first visit to now, there was improved disc edema while on the Diamox, and they were tolerating the Diamox well. You can see here from the RNFL, the average RNFL thickness was down to the low 120s, mid 120s range, and they were doing better. At this point, because of the news of the recent pregnancy and then also their improvement, we decided to stop the Diamox after a discussion with the patient, and then we continued with weight observation alone. And we saw them again in follow-up. There was a happy ending. This patient had resolved disc edema and mom and baby were healthy. But as you can imagine, in a patient with much more severe papilledema or reduced visual function, perhaps a weight observation alone wouldn't have been sufficient for them. So Let's take the example of a case reported by Dr. Felix Tyndall, who's kindly offered for us to have him share his case report that he's published. He published a report of a patient, a 28-year-old female who was 13 weeks pregnant with fulminant IIH in pregnancy, and they had reduced visual function, reduced visual acuity 20/40, 2200. There was an RAPD because of the asymmetric disc edema. There was reduced color vision, cranial nerve abnormalities, and there was severe bilateral papilledema with markedly reduced visual field loss as well. So taking it back to our patient, would this patient really be able to get off with just weight observation alone, or would they need more escalating means of therapeutic management? And this is just a sort of a primer. This permutation of our case is a primer that we'll get into next slides on management of severe fulminant IIH in pregnancy. So let's get our first poll question up. I have it here on the slide, but Amandeep, if you don't mind. So I'll be reading the question out. Where appropriate, which treatment options can be safely utilized in pregnant IIH patients? Weight counseling alone, weight counseling and acetazolamide, the first two options and serial lumbar punctures, or all of the above, including CSF shunt or optic nerve sheath fenestration. So we'll give everyone a bit of time here. And there is no, I don't want to say that there's like a purely a right answer. We're going to be going into all of these options at a later point, but it's just to get the audience to think of what is allowed, what isn't allowed, what contraindications are there. So we'll give it a bit of time.
I don't think I've ever seen such a split result here. So
that's good. That's exactly what we want. And hopefully everyone will be gaining a little bit from the talk then. So best case scenario for us. So let's get into the meat potatoes of the talk here. We'll talk about IIH and pregnancy. And as Dr. Sharma alluded to, there are physiologic changes that occur in pregnancy. There is increased blood volume and cardiac output. There's a hypercoagulable state. There's increased insulin resistance, weight gain, immunosuppression, and changes in hormones. So considering what we know about the physiologic changes in pregnancy, there's also diagnostic considerations to be made because of the changes that are made. And just because a patient with increased BMI who's newly pregnant walks in through the door for query papilledema, it doesn't mean that they automatically have it. We do have to think of other things, especially because they are pregnant. And because of the hypercoagulable state, for example, CVST or central venous sinus thrombosis should absolutely be considered based on the history, based on imaging, and based on their fundus exam. Superior vena cava syndrome also can increase ICP by means of reducing venous return. And in pregnant patients, we know about preeclampsia or preeclampsia-induced hypertension. So always very important to check the blood pressure in the office, check the fundus, make sure there's no retinal hemorrhages, make sure their story lines up with IIH and also with corroborating imaging as well. We know that anemia is also prevalent in the pregnancy population because of the increased blood volume and cardiac output. So that's just another thing. Check the CBC before, make sure you hone in on that. And then lastly, just because a patient's pregnant, it doesn't mean that they can't have another secondary cause of raised intracranial pressure or an alternative cause like demyelinating disease or leptomeningeal enhancement. So it's always important to try our best not to look at this as a silo approach and avoid our biases and really rule out every other cause because we don't want to be missing these rare cases. And we know that from the diagnosis, the modified Dandy criteria is one of the academic gold standards here. And I'll just briefly be going over this. The modified Dandy criteria outlines the necessity for a normal neurologic exam, except for cranial nerve abnormalities, which can be seen in severe papilledema. Typically, imaging with MRI, MRV with contrast is done, and it must not show any evidence of a secondary cause of raising intracranial pressure or disc edema like leptomeningeal enhancement or demyelinating disease. And then an LP is also a component of this formula, which requires a normal CSF composition and a high opening pressure. And the reason I outlined this box in red is because, as I alluded to earlier, it's not always done, especially in patients with a typical demographic with high quality imaging, but it is included in the Dandy criteria. And then I just included a small permutation here about the Friedman criteria, which adds papilledema as one of the criterion for diagnosis.
So Yusuf, just to go back for a second. So if they are the typical demographic, is this suggesting you can skip the MRI or the neuroimaging?
Not the MRI. So just
Just the venous.
and not even necessarily the LP, but there was a really interesting article, a point counterpoint with Dr. Margolin, who argued against the use of an LP in a typical demographic patient. So young obese female with high quality imaging. So they had to have had an MRI with contrast, MRV with contrast. And what they found, and they cited a few different papers, that there was no misdiagnosis of non-IIH in a typical demographic patient with high quality imaging. But as I'll get into a bit later in the talk, if a patient's pregnant and they may not be able to get high quality imaging, what do we do from there? So the imaging is necessary, whether that's with or without contrast. I'll be getting into that too. But the LP is a point of contention that's, I guess, based on where you practice, there's different preferences.
Got it.
So moving into the investigations in pregnancy, well, we know, taking a step back just in general with IH, the standard workup according to the Dandy criteria is MRI and MRV plus minus MRV with contrast, as well as a lumbar puncture. But going into the pregnancy population, is this necessary and is this safe? There was a study in Ontario, actually, that looked at all pregnancies from 2003 to 2015 and looked at the rate of MRI in pregnant patients in over 1 million patients. And what they found was that MRI without contrast was safe in any trimester. However, MRI with contrast and MRV with contrast was unsafe during any point in pregnancy, leading to teratogenic effects. So we're in a bit of a dilemma here with the pregnant patient. So if we do know that high quality imaging is necessary to rule out secondary causes of raised intracranial pressure and rule out demyelinating disease, leptomeningeal enhancement, what are we supposed to do in this population? And an MRI without contrast isn't the most sensitive at ruling out these entities. There is a modality of imaging called a time of flight MRI, MRV, which is a non-contrast study, but it does provide contrast through between the vessels and stationary tissues by inducing blood inflow effects, but it still doesn't 100% live up to the gold standard of the gadolinium MRI. But it is something that you can have in your back pocket, and at least it's a little bit better than the MRI without contrast. So just keep that in the back of your mind here. As far as lumbar puncture goes, there's no contraindications to lumbar puncture in pregnancy, and it is safe. And when we talk about the utility of lumbar puncture, we mentioned that it was a point of contention in the overall population. But in pregnancy, we would argue that it carries much more added benefit and weight because it can compensate for the non-contrast imaging that is necessitated in pregnancy and can kind of make up that ground and ensure that we're not missing any secondary causes of raised intracranial pressure or leptomeningeal disease, demyelinating disease, and so on. So in the pregnant population where high quality neural imaging can't be sought out, a lumbar puncture, we'd argue, is much more important. And in Dr. Margolin's counterpoint to lumbar puncture is necessary, he did incorporate the need for high quality gold standard imaging. So if we can't get high quality gold standard imaging in a pregnant patient, there is an argument for lumbar puncture for sure in the pregnant patient. So let's talk a little bit about the clinical course of IIH in pregnancy. And the question here is, does IIH in pregnancy differ from IIH in non-pregnant individuals? And spoiler is yes. So I'll be speaking about this nice article here by Dr. Thaler and his group, which broke patients up into 4 different stratified groups. The first being IIH diagnosed in pregnancy. The second, established IIH who then became pregnant. The third, pregnancy exclusively occurring prior to IIH diagnosis. And then the last, patients with IIH who are never pregnant. And what they found was that patients who were pregnant and then got IIH had a worsening papilledema trajectory if they were diagnosed with it in pregnancy, as well as a longer recovery time of the RNFL. So you can see here in the red circled areas, patients who were pregnant and then got IIH initially got worse, as opposed to patients who had IIH and then became pregnant or were not pregnant at all and had IIH. They actually experienced improvement from the get-go of diagnosis and treatment. There is also worsening pre-parametric mean in this population of patients who are pregnant and then got IIH. However, there's a similar headache burden and visual acuity, and this is supported by other studies. So the take-home point here from this study, and also supported by other studies, is that patients who are pregnant and then get IH are not the same and should not be treated the same as patients who are pregnant who get IH and then also non-pregnant patients. There are some obstetrics considerations for people who are pregnant and then have IH, and notably, vaginal delivery is not contraindicated, although a patient themselves may elect for a C-section or at or delivery at a high-risk OB center just because of their diagnosis. There is a similar rate of spontaneous abortion, so it's not higher in the IH population. However, there is a higher incidence of complications associated with pregnancy, such as gestational diabetes and preeclampsia. And this may have something to do with the increased weight that people with IH are prone to getting the IH, but it's not 100% clear at this point. Moving into the treatment of IH in pregnancy, so going back to our slide question or our poll question, we know from the IH treatment trial that weight loss is a proven strategy, but the 5 to 10% weight loss target isn't exactly a realistic expectation for all patients. In the pregnant population especially, it's not really okay to be asking a pregnant patient to lose weight. And we know this isn't healthy for the mom and healthy for the baby. What we do know, though, is that in pregnant patients, excess weight gain can lead to postpartum weight retention, which can lead to IH deterioration or recurrence in future pregnancies. So although there's no evidence-based guidelines on weight gain in IH, it is important to talk to the patient, talk to the obstetrician as well, and work as a team to kind of figure out what their weight goal targets are. And it really is just best to have them adhere to the normal standardized weight gain recommendations based on their pre-pregnancy BMI, which I included here on the slide. And you really can, there is that myth of eating for two when you're pregnant. And as you can see here from the slide, you don't really need to be eating double, but it is important to try to adhere to those recommended weight gain targets so that you don't get worsening IH or recurrence. And this should be a foundation that you discuss with all your patients. As far as Diamox or acetazolamide goes, there are animal studies which demonstrate congenital malformations in mice that have been reported, but in the human population, there have been very rare single case reports outlining teratogenic effects. On the counterpoint, there are retrospective studies that showed no difference in pregnancy outcomes from patients who took Diamox versus not taking Diamox, even in the first trimester. And this is corroborated by other studies as well. So where does that leave us? It leaves us at a category C, which unfortunately doesn't give us much information apart from we don't know whether it's purely harmful or harmless. So what the general consensus here is that most clinicians tend to stop acetazolamide once pregnant, especially if they have mild IIH without significant symptoms. But if you are going to be prescribing it, it's important to have a discussion with the patient and obstetrician, weighing the benefits and the risks and considering the severity of the symptoms. So having it be a shared decision is especially important. And, you know, there is an indication if a patient has severe IIH. It is important to avoid in the breastfeeding population because there are low levels found in the breast milk. So now let's loop back to Dr. Tyndall's case and that permutation off of ours about the fulminant IH in pregnancy with the reduced visual function. We knew that weight observation alone probably wasn't going to cut it, but what are we allowed to do in pregnancy and what can and should be done? And we know that from Dr. Tyndall's case, this patient was managed with acetazolamide 3,000 milligrams daily, and then they received a lumbar drain. And the lumbar drain allowed them a temporizing measure before they were able to get an occipital VP shunt. So it bought them a bit of time before definitive surgery could be undertaken. At this point, the acetazolamide was tapered, and then 6 months after the surgery, a healthy baby was born by a C-section. And you can see here from the post-op visual fields, they did have improvement in their visual field and their visual function. So kind of as a stem off of his case, if there is severe papilledema or fulminant papilledema in pregnancy, Diamox should be considered, of course, after a discussion with the patient and OB. There's not really a huge role for diuretics or steroids. We know that topiramate is absolutely contraindicated, and methazolamide, the sister drug of Diamox, falls into the same category. see FDA recommendation. But if a patient can't tolerate the Diamox or is adamant against it, serial lumbar punctures or a lumbar drain is a good temporizing measure, like that was done in Dr. Tyndall's patient, that can buy a patient time until surgery or delivery. And then at that point, a VP shunt is probably one of the more common surgical procedures in IH pregnancy that's fulminant, as opposed to nerve fenestration or venous sinus stenting, which carries general anesthesia risks and anticoagulation risks, which, we don't always really want a patient who's pregnant to be anticoagulated because of the risks associated there. An induction of labor can be considered as well if there's non-responsive IH and a patient's close to being delivered at that point. Kind of giving an overview of the management of IH in pregnancy, there really has to be a foundation of interdisciplinary communication. So it's just so important to pick up the phone with the obstetrician and make sure that they're on the same page with you. And then patients really do need an increased frequency of observation every 6 to 8 weeks, and just have to be carefully monitored a bit more, because we do know that they're a bit more labile and they have a worsening trajectory of papilledema. Weight counseling is also a foundational conservative measure, but it may not be realistic for all patients, but it's still important to educate them on the expected weight gains in pregnancy. Moving on to a bit more escalating severity, it's okay to consider oral carbonic anhydrase inhibitors like Diamox, but if a patient can't tolerate them, or if they have fulminant, very severe papilledema, you probably have to escalate therapy a bit more. And at that point, you can consider serial lumbar punctures, lumbar drain, like we mentioned, or a surgical intervention with a VP shunt, and then also having the patient deliver at a high-risk OB center. So kind of to summarize this talk, I'll be just reiterating some take-home points to drive the points home. Ensure you rule out other causes of increased ICP in pregnancy. MRI without contrast and lumbar puncture are safe, so you should avoid gadolinium and consider a time-of-flight MRI. IIH diagnosed during pregnancy has a worse trajectory. Acetazolamide may or may not be teratogenic, and we generally avoid this in the first trimester and use where needed after, with discussion with the OB and the patient. Serial lumbar punctures or lumbar drain can be used as a temporizing measure, and a sensitive discussion about weight targets with a tailored patient approach is recommended. And lastly, collaboration is key. So I'll be passing it along to Austin, who will present our second case, the not so common.
Thank you, Yusuf. That was an amazing overview, and thank you everyone for being here. Can you see my slides well? Awesome. Yeah. So thank you, Dr. Sharma, for this opportunity to chat today. My name is Austin Pereira. I'm a fourth-year resident in the ophthalmology department. I'll be describing a very interesting clinical case that Dr. Sharma had the pleasure of managing last year, and we're just going to keep it as a mystery case to start off. So this patient presented to Dr. Sharma's practice, a 26-year-old woman, 37 weeks pregnant, G1P0, so this is her first pregnancy, noting that she was describing an acute on chronic decreased visual acuity in her right eye. It's been going on ever since the start of her pregnancy. This was also associated with this right-sided facial pressure, which is quite vague in description. She had an unremarkable current pregnancy screening. So she went to all of her screening with her OBGYN and everything was unremarkable. She had a past medical history of hypothyroidism, of which she was taking levothyroxine, and no family history of any eye disease. Of note, she did disclose that she has this long-standing poor vision with a baseline of 2100. This was diagnosed with a visual acuity of 2100 in Mexico, and she recently moved to Canada last year. So for this prior ocular management, this baseline was obtained in 2019. And so ophthalmologists in Mexico noted an anomaly of the right optic nerve head. An MRI was also completed at the time, but was not currently available for our practice. Her last ophthalmology follow-up was in Mexico in 2021, but she recently saw her outside optometrist in Canada, who urgently referred the patient to Dr. Sharma for consultation. So for her eye examination on first presentation, her visual acuity had fallen from 2100 to 2200 in the right eye and was 20/20 completely normal in the left eye. She had no color vision in that right eye, and there was a relative afferent pupillary defect. Slit lamp examination was normal. And here we have bilateral fundus photos of the right and left eye. I'll let you all kind of take these in. I'll say that the left eye is unremarkable, but there's definitely some striking anomaly in the right optic nerve head. I'll just zoom in a little bit more so you can get a better look at that right optic nerve. And while you all take this in, maybe a PGY2 can volunteer to describe what they see on this photograph. Not everyone at once.
I think we're getting someone on the mic in the room.
Somebody.
Sandra, you can pick. Or just anyone is fine. It doesn't have to.
Yes. So it looks like a color fundus photo of the posterior pole of the right eye with an anomalous optic nerve head. There's some surrounding PPA around it, and also some hyperpigmented foci. Otherwise, the macula and the vessels look pretty normal.
Awesome. Yeah, thank you, Brian, for volunteering, and a great description. So definitely there's this anomalous optic nerve head we can appreciate in the black arrow in the right eye with this surrounding atrophy. Kind of looks a bit atypical for PPA, but just some atrophy we can appreciate around the optic nerve, and these kind of hyperpigmented foci as well, more nasal to the optic nerve. And here we have an OCT of the RNFL and optic nerve head. And I'll zoom in a little bit more so we can take in the key features. We can appreciate that there's definitely an increased RNFL thickness in the right eye compared to the left, as well as an increased RNFL thickness plot for supranasally and inferiorly in the right eye compared to the left. And here we have 24-2 Humphrey visual fields that were conducted, and we can really appreciate this 3-quadrant deficit and as well as global depression in the right eye compared to the left, as well as this kind of early arcuate pattern developing in the right eye. Now, Dr. Sharma really worked hard to obtain the images that were taken in Mexico in 2018, and they had this beautiful montage of images taken where they had the color fundus photo, red-free fundus autofluorescence, and early, mid, and late photos of the IVFA, where we can see here in the right eye. I'll let you take that all in right now from 2018, as well as the normal images from the left eye. And now I've put the late IVFA images together here, and maybe a more senior resident can take a stab at describing these photos. Anyone in the resident audience?
So these are bilateral IVFA images, as you said, in the late phase. And you can see the most striking finding in the right eye is hyperfluorescence in this kind of patchy pattern around the optic nerve head with kind of punctate areas of hyperfluorescence within that. And it seems to be limited to that area with no leakage beyond those borders.
Awesome, Seema. Yeah, perfect as always. So you can really see the IVFA. You can really appreciate this punctate areas of hyperfluorescence, kind of around it is punctate areas of hypofluorescence, but really hyperfluorescence around the lesion that we all appreciated. And here we have OCT macula images of the right and left eye extending towards the optic nerve, and we can really appreciate the optic nerve is elevated in the right eye compared to the left, and it kind of extends to these kind of hyporeflective cavities in the internuclear layer of the right eye. Left eye is unremarkable. And we can see the elevation of the nerve here in the green arrowhead. So with all of these kind of multimodal images taking into account, we have our poll question. What do you think the working diagnosis is for this patient? The first option is an optic disc cavernous hemangioma. Second is a retinal capillary hemangioma. Third, peripapillary choroidal neovascularization. And D, an optic nerve glioma. Give you a few seconds to think about your answer.
Great images, by the way.
Yeah, Dr. Sharma did a great job finding those. Those are amazing montage that the Mexican ophthalmologist put together there.
There are your results, Austin.
Awesome. Yeah, that's amazing. So majority of people are going with an optic disc cavernous hemangioma, with other people thinking of the other options. So we agreed that with a Morgan diagnosis is most likely an optic disc cavernous hemangioma. So what is this entity? Optic disc cavernous hemangioma, or vascular malformation, and another name for it, was first described by a lot of things in ophthalmology by Gass et al. In 1971. It's a rare presentation of these vascular malformations. Only less than 1% of intracranial vascular malformations are optic disc in nature, but it's quite common intracranially. Only 42 documented cases are currently in literature of optic disc cavernous hemangiomas. And here is a picture of the first citation of this entity. Optic disc cavernous hemangiomas are described as benign tumors of rapidly proliferating endothelial cells that are also described with hyperplasia of parasites. There's a known association with these benign tumors with hormonal factors. For example, cavernous liver hemangiomas are only found in pregnant women due to increased estrogen levels. And they can cause vision loss due to the compression of the optic nerve, but not only inside of the anterior aspect, but also compression of the chiasm or optic nerve tract. Luckily, there's no malignant potential with these lesions. And with the OCAP coming up pretty fast for us residents, some things you may see on your OCAP are a mulberry appearance on pathology, as well as a grape-like clusters of thin-walled saccular angiomatosis lesions. Very OCAP-y answer. It also is a phakomatosis first described by Gass in 1971, where you can have telangiectasias of the skin with cavernous hemangiomas intracranially and in the eye. The pathophysiology of this disease is usually familial. 40 to 60% of cases are familial origin due to aberrant genes in CCM1, 2, or 3. CCM codes a genetic product that interacts with neural tissue and interacts with the endothelial tight junctions and allows and supports the cytoskeletal proteins during angiogenesis. So when this gene product has a dysfunction, it activates Rho-A kinase, or ROC-A, leading to an endothelial barrier dysfunction and leads to the saccular angiomatosis lesion to develop. Sporadic cases of this disease is usually a single lesion, as seen in our patient, or familial could be multiple lesions intracranially in the eye and throughout the body. It's found in actually 0.4 to 0.8% of general population, the more you may think, and it actually accounts for 10 to 25% of cerebral vascular malformations. Presentation of these cavernous hemangiomas are typically throughout the body, not only in the eye, that's more great where, but really in supratentorial compartment. A lot of our neuroradiology colleagues may find this incidentally on their MRIs. Also can present infratentorial region in the spinal cord and less commonly in the cranial nerves, most commonly manifesting as seizures, intracranial hemorrhages, and with focal neurological deficits without evidence of recent hemorrhage. But for us ophthalmologists, complications of the optic disc cavernous hemangioma include vitreous hemorrhage that may require vitrectomy. Here are 2 cases that were published in American Journal of Ophthalmology and Arch Ophthalmology that demonstrate a persistent vitreous hemorrhage that ended up requiring vitrectomy for these cavernous hemangiomas of the optic disc. Interestingly, these cavernous hemangiomas can have progressive growth that can lead to the optic nerve head compression, and that leads to progressive vision loss, which was demonstrated by a case report in 1994 by Kushner et al. And a very interesting presentation, which kind of mirrors our patient, which is a case report published with Vela et al., where a 29-year-old healthy woman, 20 weeks gestation, had 3 weeks of a paracentral scotoma in her right eye. She presented with a sub-ILM hemorrhage secondary to the optic nerve head cavernous hemangioma. This, luckily for this patient, this case report resolved over 1 month. They published a beautiful case, a photo of their pathology where you can see this triangular shaped sub-ILM hemorrhage. Now, for these pregnant patients, especially, labor can actually induce a vitreous hemorrhage for these cavernous malformations. And this was shown in a case report by Smith and Joseph, where during a spontaneous vaginal delivery, labor induced a vitreous hemorrhage that ended up requiring a vitrectomy for the cavernous hemangioma. Luckily for our pregnant patients, though, due to the association with pregnancy and estrogen levels for the growth of cavernous hemangiomas, a number of reports analyze the response of these lesions following delivery, and a number have demonstrated resolution of the oculomotor and sensory deficits in cavernous sinus cavernous hemangiomas and optic disc cavernous hemangiomas after pregnancy. So if there is no complications with these lesions following pregnancy, there's usually regression of the lesion. And what are the treatment options we have? So the mainstay for the orbital cavernous malformations still remains as a surgical excision, especially if it's leading to progressive vision loss, if it's leading to seizures or alternative manifestations. There's also rare reports of the optic disc cavernous hemangioma being treated with photocoagulation, especially if they are leading to recurrent vitreous hemorrhage, but they've been demonstrated with mixed results. So really close observation is the mainstay of treatment for these rare patients. So let's tie it back to our patient, our lovely lady who again was 26, who had 37 weeks gestation, first pregnancy, diagnosed with an optic disc cavernous hemangioma. Dr. Sharma decided to urgently consult our maternal fetal medicine specialists or MFM specialists, and they discussed the risks and benefits of assisted second stage versus primary C-section for the patient. And the exact quotes from the impression was a rare presentation that is poorly understood in pregnancy. But because the patient's vision had declined from 2100 to 2200 and the risk to further compromise of the patient's vision, the ultimate recommendation by our MFM colleagues was a primary cesarean section for delivery. And luckily, I can't say for the outcome, was a healthy mom and baby with stable visual function for the mother. So in summary, optic disc cavernous vascular malformations are very rare, especially in the optic disc, but can occur, especially in pregnancy due to the changing hormonal levels. Ocular complications can include, as we see in our patient, optic disc compression, and other reports, vitreous hemorrhage and sub-ILM hemorrhages, and really requires, similar to Yusuf's case, an early consultation with high-risk obstetrical services to get their gauge as to what they would prefer for the treatment of the mom. And regression of the lesion can be seen post-pregnancy. Thank you so much, Dr. Sharma, for the opportunity, and Dr. Rai for having us today.
Yeah, that was incredible. Both cases were very cool. There's a question for you guys, maybe for Dr. Sharma. Can you comment on antipsychotic drugs in IAH?
So I'm not aware of any strong association between any antipsychotic and IIH. I mean, as with a number of medication-induced ophthalmic presentations, there are case reports. With respect to antipsychotics, I've come across case reports involving risperidone. I think more likely than an antipsychotic would be a potential association with lithium, which I think is a mood stabilizer rather than antipsychotic. Lithium has been implicated in IIH. Even with the case of lithium, though, I think although this association has been proposed, I don't know that we're clear on whether it's coincidental or causal. So the short answer is I'm not aware of any medication in that domain that is as strongly associated with IIH as the ones that we talked about. We haven't looked at this specifically, though, of course.
Got it. Thank you. And just a question for myself. With that last case, have they reported complete resolution or partial resolution of these lesions following delivery? Just out of curiosity.
Pardon me, can you say that again? You just cut off in the Wi-Fi.
Oh, the cavernous hemangiomas, is it a partial resolution, or or in some cases, is there a complete resolution?
All the cases, which are 3 that we report in literature, it was that they had a partial resolution, so it did not progress, one, and the size of the lesion documented on fundus photos and OCT decreased in size. So there's always a sign that there was an optic nerve anomaly in the future, but never went away, but it decreased in size and function, I guess, or manifestation.
Fascinating case.
Thank you.
I'll just add, and Austin did a great job at this, looking at the photos from 2018 from Mexico and then the disc photos that we obtained at the time of the visit with me. And you can see by comparing the two and zooming side to side that there was a marginal increase in size.
I'll go back here just so we can see that for Seema described it perfectly here as well. So here we can see that back in 2018, here's the size on the top left. But if we go back to our photo, if we just appreciate that, you can see that it's a bit more atrophic in our case. So it's a bit smaller and a bit more atrophic here.
Well, that's a very cool case. So, well, there's no further questions in the audience, but I do want to thank you guys for a wonderful round. Rahul, that was a great summary at the start, and Yusuf and Austin, those are great cases that were presented. So I do want to thank you for that. I certainly learned quite a bit this morning, so thank you for the review. Thanks to the audience. There is a link to complete an evaluation. Please take a look at that before you sign off. Enjoy the rest of your Friday. We'll see you guys next week. Bye.